screen. Hello there, and welcome to episode 8 of our APSC-EECC Core Cardiology Review series. My name is Ezman, and today we'll be diving into the overarching topic of acute cardiovascular care, specifically sort of discussing about aortic and peripheral arterial disease and venous thromboembolisms. So just a bit of introduction about our society and our webinar series. The APSC, in collaboration with the EECC, presents the Core Cardiology Review series, which is a webinar series designed to provide a comprehensive update on various core or general cardiology topics. It also serves as a good preparatory course for cardiologists in the Asia-Pacific region planning to embark on the EECC test. So along myself, Ezman, we have four other course core directors. So Vishnu, Aisha, Jonathan, and Wei Ting, as well as our two advisors, Professor Jack Tan and Professor Chris Plummer from the UK. So alongside myself, I have another chair joining me today, someone who really knows the field very well, both arterial and also in terms of venous thromboembolism. So Assistant Professor Guan Tan from the Chinese University of Hong Kong Medical Center, Hong Kong. And we have two wonderful speakers today, Dr. Donna Shu-Han Lin from Taiwan, who'll be talking to us about aortic and peripheral arterial disease, as well as Dr. Wong Woei from Singapore, who'll be talking to us about venous thromboembolisms. So a bit of disclaimer and housekeeping rules. The content of this webinar is copyrighted by the APSC. The views and opinions expressed are those of the faculty members and do not necessarily represent those of the APSC. This webinar is actually currently being live streamed via APSC Facebook and YouTube pages, and it will be recorded for future viewing. You will also receive your certificate of attendance upon completing a survey, which is sent via email post-webinar. Feel free to engage with us throughout the discussion for today's episode via the Q&A chat box at the bottom, and we'll try to moderate as much as possible. Just a bit of advertising on our side. Next week, we'll be having our APSC 2025 Congress in Busan. There's still a lot of time to register for those interested to join, so please do. And alongside the whole Congress, we also have a pre-Congress session dedicated to the EECC, which is an EECC preparatory course. Just a reminder that this EECC preparatory course isn't just for exam takers, but also for those general cardiologists who are really interested to sort of brush up on their general cardiology. So again, please do join us. Now, without further ado, let's get started. I'd like to introduce our first speaker, Dr. Donna Shu-Han Lin from Taiwan, who again will be talking through aortic and peripheral arterial diseases for us. Donna, the floor is yours.
Okay, so can everyone see my slide? Thank you, Ezman, for the very kind introduction. And I am Donna Lin from Taiwan, and it's a great pleasure to be joining everyone online again in this EECC review series webinar. And my part is to go through the aortic and peripheral arterial disease. And to be honest, this is a huge piece of guidelines to go through. So for the limitation of time, there are some parts that we will just go through really quickly. And these are my disclosures. So first of all, I would like to remind you that the 2024 ESC guidelines has combined peripheral artery and aortic diseases. And in the previous version, the 2017 ESC guidelines on PAD and the 2014 ESC guidelines on aortic diseases had not combined these two diseases together. And there are some considerations. I think for one thing, being both atherosclerotic cardiovascular diseases, the pathophysiology and the mechanism of these diseases do have something in common. And the fact that the prevalence of any type of PAD has been rising over the past 2 decades. And this has been primarily because of the aging of the global population. As you can see here, how the prevalence of PAD increases with age. So in addition to, like I said before, all PAD are atherosclerotic in nature, and they do share modifiable risk factors that we know of, such as diabetes, hyperlipidemia, hypertension, smoking, etc. And there are also emerging non-traditional risk factors that we now know to have some significance, such as apolipoproteins, lipoprotein A, obesity, etc. So the understanding of atherosclerosis has also been advancing over the past couple of years. Now, like I said before, just over the very limited time being, we can separate the guidelines into lower limb PAD, aortic diseases, and diseases in other vascular beds such as mesenteric arteries, renal arteries, etc. And for the interest of time, we would not be able to go through these vessels today, and we will start first with the lower limb PAD. So I think many of you are familiar with the classification of symptoms in lower limb PAD using the Rutherford or the Fontaine classification. And both these two classification symptoms basically sort the patients according to their symptoms. So for example, Rutherford 0 class would mean asymptomatic PAD, whereas 4 to 6 is chronic limb-threatening ischemia, and patients with Rutherford 5 or 6 disease would have some level of tissue loss. And we must remember that the outcomes of patients with lower limb PAD are actually very poor cardiovascular wise. This is data from the REACH registry, where they found that patients with PAD, but no history of MI or stroke, actually had a higher incidence of MI or stroke or cardiovascular death during follow-up compared to patients who had an MI or stroke, but no PAD. And in fact, in patients with chronic limb-threatening ischemia, this is data from the BEST CLI trial, and you can see how over a mean of around the follow-up of 2 years, patients with chronic limb-threatening ischemia, almost half of these patients either have a major amputation or all-cause mortality. So when we're looking at patients with lower limb PAD, we must remember that they are at elevated risks of not only limb events, but also cardiovascular and cerebral vascular diseases. And it is due to these diseases that they have such poor outcomes. So then we think, okay, so how do I know if the patient has PAD, lower limb PAD or not? And I think everyone is very familiar with ankle brachial indices. So basically you measure the pressure in the arm and the ankle and you do a simple math to see the patient's ABI. But just a reminder that patients with a very high ABI, specifically, that's my sorry. So very high ABI, specifically something higher than 1.4, actually denotes non-compressible arteries, and it is actually abnormal in that sense. So in that case, you should complement your evaluation with a toe brachial index to supplement the evaluation. And in patients in whom you suspect to have chronic limb-threatening ischemia, we can evaluate the tissue perfusion with transcutaneous oxygen partial pressure, TCPO2. So in the previous version of the ESC guidelines, they actually gave this table of recommendation for patients who should be screened with an ABI. And you can see how in that version of the guidelines, they actually listed patients who are at higher risk of atherosclerotic cardiovascular disease, who already have disease in other vascular beds, or in patients with elevated risk factors such as diabetes. But in the current 2024 ESC guidelines, they did not present with such a table. They only listed the specific patient populations that need to be screened in the text. And in terms of recommendations, they did mention that patients with diabetes or CKD and normal resting ABI, you should consider a TBI. Patients older than 65 years old with multiple risk factors, then you should screen with an ABI or TBI. But the level of recommendation is two-way in the current version of the ESC guidelines. So let's say you face a patient who you suspect to have PAD. So the first thing you do, you look at the patient's symptoms functionally, and then you do hemodynamic and vascular assessments with either ABI, TCPO2, Doppler, and you look for wounds. And then you ask the patients for their symptoms. So traditionally, what we talk about what we mean when you say symptomatic PAD, we specifically mean either intermittent claudication, chronic limb-threatening ischemia, or acute limb ischemia. But we now recognize that there is a large subset of patients who either are asymptomatic or are not diagnosed entirely. So this figure is from the guideline from the European Surgical Cardiovascular Surgeon Society, where they illustrated that the most of the patients with PAD are either asymptomatic or underdiagnosed. So the patients that we actually see is only the tip of the iceberg. In fact, in the ACC-AHA guidelines on PAD, also from the 2024 last year, they included a subset of asymptomatic patients with PAD into consideration. And it is to be reminded that even patients without symptoms with PAD, they may have some level of functional impairment, which is why they do not present with symptoms of PAD. So let's say we look at a patient you diagnosed with chronic PAD syndrome without wounds. So the most important thing we need to start with is, of course, optimal medical therapy. And coming back to the risk of cardiovascular diseases in PAD, you must remember that it is the cardiovascular risk, the MACE risk, that determines most of the survival of these patients. So when we're talking about optimal medical therapy in PAD, we're not just looking at the prevention of limb events, but more importantly, the prevention of cardiovascular events. So if we look at the ESC, the figure from the ESC guidelines, they beautifully illustrated how we both need to address the general cardiovascular risk and also the limb symptoms. And in that case, we need to treat patients with hypertension, hyperlipidemia, diabetes, supplement with antithrombotic therapy or exercise training. So let's start with optimal medical therapy in these three areas: thrombotic risk, lipid risk, and diabetes risk. And in terms of the thrombotic risk of PAD patients, antiplatelets have been demonstrated to reduce the risk of MACE in symptomatic PAD. So specifically, this was a meta-analysis looking at aspirin and clopidogrel, and they found that in patients with symptoms of PAD, patients who had a revascularization procedure before or intermittent claudication, the use of antiplatelets reduced the risk of MACE. And in the Capri study, which compared clopidogrel against aspirin, they found in the subgroup of PAD patients, the benefit of reducing MACE with clopidogrel seems to be more significant than other subgroups. And later on, we have the low-dose rivaroxaban combination with aspirin, what we call dual pathway inhibition. This was first demonstrated in the COMPASS study, where they looked at stable PAD and high-risk CAD patients. And they found that low-dose rivaroxaban plus aspirin reduced both MACE and MALE in chronic symptomatic PAD. Furthermore, with the Voyager study that looked at PAD patients post-revasc, and they also found that low-dose rivaroxaban plus aspirin reduced MACE and MALE after procedures for PAD. So based on these trials and data, currently in the ESC guidelines in patients with chronic symptomatic PAD, if the patient does not present with high-risk limb features or high-risk comorbidities, then they gave aspirin or clopidogrel, SAPT, a class 1 recommendation. And in patients with higher risk of thrombotic events, they would recommend the use of aspirin plus low-dose rivaroxaban with a class 2A recommendation. And in patients after revascularization and those without high bleeding risk, then you can consider the use of dual pathway inhibition with rivaroxaban 2.5 milligrams with aspirin. In those with a higher bleeding risk, they would recommend a long-term SAPT use. Now, just a reminder that this is a little different from the ACC/AHA guidelines, also from last year, where they actually gave class 1 recommendations to low-dose rivaroxaban plus aspirin in both chronic stable PAD and those post-revasc. Next, let's move on to lipid risk. I think the benefits of statin use in PAD patients is pretty well documented. You can see how it reduces all-cause mortality, cardiovascular mortality, MACE, and also amputation risk in patients with PAD. More importantly, in the Fourier trial, which compared evolocumab against placebo, they found that in the subgroup of patients with PAD, the reduction of MACE associated with evolocumab use was more significant than the patients without PAD. And not only did evolocumab reduce the risk of MACE, it also significantly reduced the risk of MALE limb events in the Fourier trial. And the reduction of limb events was not limited to patients with the PAD diagnosis, but also to patients without known PAD when recruited to the trial. So currently in the ESC guidelines, the lipid goal for patients with PAD is less than 55 milligrams per deciliter of LDL, or more than 50% reduction from baseline, starting with a statin and adding on ezetimibe, PCSK9 inhibitors, or even bempedoic acid if the patient does not reach his or her LDL goal. Next, we'll look at the diabetes risk. I'm sure most of you probably have heard of or are familiar with the increased risk of amputation that was signaled in the Canvas trial. But later on, with other SGLT2 inhibitors coming up, this signal was not statistically significant. But you can probably appreciate how in the meta-analysis, there still seems to be a little trend towards increased amputation risk or limb events with SGLT2 inhibitors. On the other hand, with GLP-1 receptor agonists in the LEADERS trial, liraglutide in a post-hoc analysis showed to reduce diabetic foot ulcer-related amputations compared to placebo. And more recently, just published in the ACC. STRIDE compares semaglutide against placebo in patients with type 2 diabetes and PAD. But just a reminder that the STRIDE trial enrolled patients with very mild symptoms of PADs, specifically Rutherford grade 1, Fontaine 2, and the primary outcome was a change in maximum walking distance and not MACE or MAIL. And so in the STRIDE trial, the primary outcome was walking distance. So the patient had to be able to perform a treadmill loading test, which excluded many of PAD patients, to be honest. But regardless, with the primary outcome, the use of semaglutide led to a significant increase in maximum walking distance compared to placebo. And in an exploratory analysis of lower limb revasc, male and all-cause mortality, there seems to be a signal of reduction of male events with the use of semaglutide compared to placebo. Currently in the guidelines, the ESC guidelines recommend tight glycemic control for patients with PAD, specifically a glycated hemoglobin of less than 7%. And even though there had been some controversy regarding SGLT2 inhibitors in these patients, because of the massive cardiovascular benefits of SGLT2 inhibitors, the guidelines still recommend with a class 1 recommendation to use these drugs in patients with DM and PAD. Now, of course, the GLP-1 receptor agonists have with proven cardiovascular benefits should be used, and metformin can be considered to add on for glucose control. In terms of optimal medical therapy, once you have done that, another thing that you should consider in symptomatic PAD is supervised or structured home-based exercise training. And I know this sounds actually pretty interesting because supervised exercise training programs are not that easy to do. Specifically, there are specific definitions. First, it has to be done 3 times a week. Each session has to last at least 30 minutes and the program duration of at least 12 weeks. And the patient needs to exercise until there is some level of pain. So it's not just a leisurely walk. It's actually training to some pain in the legs, and then they rest, and then they start exercising again. And the benefits and mechanisms of supervised exercise training has been demonstrated previously in many studies, how it reduces symptoms, improves quality of life, and this might be due to improvement of endothelial function, arteriogenesis, etc. Currently in the ESC guidelines in patients with symptomatic PAD, supervised exercise training is a class 1 recommendation. And I think the most important thing is that exercise training needs to be at least some intensity. It has to be 3 times a week, 30 minutes each time, last for 12 weeks, and it needs to elicit some level of pain in the legs to be effective. So next we move on to the patients with wounds or chronic limb-threatening ischemia. So these are the more severe patients with PAD. And so if a patient has been diagnosed with chronic PAD with a wound, you first need to assess the wound with the Wi-Fi score. Now the Wi-Fi score constitutes of 3 components: wound, ischemia, and foot infection, where the severity of each would be given a score, and you can add them up to have a level in the Wi-Fi score. And the level of the Wi-Fi score primarily is to assess the risk of amputation. Now, this is something very interesting happened in the 2024 ESC guidelines that I feel I must point out. So this table was the Wi-Fi score provided in the ESC guidelines 2024, and they had a citation here, 417 from the Journal of Vascular Surgery. And when I first saw this table, I thought, well, this is a little strange because this doesn't look like the Wi-Fi score I remembered. Why is that? So can you imagine if a patient has severe wound with severe foot infection, the table actually shows that the patient has a very low risk of amputation, which sounds a little strange. So then I went back to look at the 2017 ESC guidelines, and I found that the Wi-Fi score provided in the 2017 ESC guidelines showed high risk of amputation in the severe wound, severe foot infection group. So what happened? So then we go back to the original text from the Journal of Vascular Surgery. And in the Journal of Vascular Surgery, there were 2 tables. One table for the estimate risk of amputation at 1 year, which coincides with the table in the 2017 ESC guidelines. And there's another table for estimate likelihood of benefit for revasc, which coincides with the table in the 2024 ESC guidelines for risk of amputation. So I suppose there might have been some misunderstanding, and I do need to point out that even in a patient without ischemia, so ischemia 0, but severe wound and severe foot infection, he or she is still at a high risk of amputation. So how should we use the Wi-Fi score? So the question that we try to answer is who needs revascularization specifically? And to put it easier, patients who would benefit most from revasc are those with higher degree of ischemia and a more viable tissue. So in other words, if a patient has severe wound, large wound, severe infection, but no ischemia, then revascularization will probably not bring any benefit. So regardless, in the 2024 PAD guidelines, in patients with wounds with chronic limb-threatened ischemia, the vascular team assessment needs to be implemented, and revascularization should be assessed to be whether it's indicated and reasonable. And if it is, revascularization should be done ASAP in patients with chronic limb-threatened ischemia. And in patients with asymptomatic or symptomatic PAD with the wound, after proper wound care, if the wound fails to heal, then still a vascular team assessment should be implemented and revascularization assessed to be indicated or reasonable. So to summarize, in patients with chronic limb-threatened ischemia, the recognition by a vascular team is recommended. And this is a class 1 recommendation from the 2024 ESC guidelines. And regardless, in chronic limb-threatening ischemia patients, it is recommended to perform revascularization as soon as possible, also with a class 1 recommendation. So now we will quickly move on to aortic diseases. We'll start with acute aortic syndromes. I'm sure there are a number of acute aortic syndromes that we may face in the clinical arena, but most of these are aortic dissections, which actually constitute 83% of these events. And I think just a reminder for cardiologists like me, the classification of acute aortic syndromes is not just Stanford A or B or DeBakey 1, 2, 3A, 3B, but also TEM. So first we need to know the type of the aortic dissection and also the entry point of the dissection, and if there are any signs of malperfusion, because these are all high-risk features. So for a patient who presents with suspected acute aortic syndrome, then we need to look at the patient's condition, underlying diseases, the pain feature of this patient, and other examination features. And if there are high-risk features in all these 3 areas, then they would get a point for each. And for patients with a very high risk of 2 points or above, then the patient should proceed to a computed tomography ASAP. And for the low-risk patients, then you first need to exclude STEMI and otherwise complete other evaluations. I think the management of acute aortic syndrome, the first thing is, of course, rate and pressure control with the use of beta blockade or CCB to titrate the heart rate to less than 60, pain control with opiates. And if the patient still has a systolic blood pressure of more than 120, then we need to introduce vasodilators with nitroprusside or ACE inhibitors to titrate the blood pressure to less than 120. And in terms of the interventional treatment, it really goes down to whether this patient, what type of aortic syndrome the patient has, and whether the anatomy is suitable for endovascular repair or surgical repair, and if the patient has high-risk features. So for example, for type 1 aortic dissection, then open cardiac surgery is class 1 recommendation. For patients with type B with complicated high-risk features, then we need to consider TEVAR. And then if the patient is not a favorable TEVAR anatomy, then the guidelines recommend open surgical repair. And for those with a favorable anatomy for endovascular repair, then endovascular repair is class 1 recommendation. Whereas for those with uncomplicated type B aortic dissections, then you can still consider whether the patient is suitable for TEVAR and whether it has a life expectancy of more than 5 years. And if that is the case, then we can consider endovascular repair in the subacute phase. And I think in the 2024 ESC guidelines, one of the most important changes is the recognition of mechanism behind these acute aortic events. So previously, we focused mostly on the diameter of the aorta, but biochemical testing has shown that it's the resistance and dissecting forces that are not correlated fully to aortic diameter. And in fact, sometimes it's the longitudinal wall stress that changes before dissection. And so due to that, so far, before the 2024 ESC guidelines, the length of the aorta has not been implemented into a risk stratification. Another thing is the importance of aortic phenotype. specifically the shape of the ascending aorta, and also those with bicuspid or tricuspid aortic valves. So in the 2024 ESC guidelines, the high-risk features of thoracic and abdominal aneurysm rupture, they have added the length of the aorta, the ascending aorta, and also the phenotype of the root and ascending aorta, just to show how these two factors also add to the risk of possible aneurysm rupture. And for those who have a non-heritable thoracic aortic disease, who should get surgery and who should undergo observation only is quite complicated. And I like how this slide sort of simplifies things a little bit. So if the patient is not at high surgical risk, then you should consider if there are any factors prompting surgery. And these factors are high-risk features such as elongated aortas, short stature of the patient, rapid growth, hypertension, young age, family history, etc. And if yes, then surgery should be considered when the diameter is 50 millimeters or more. And if there are no high-risk features, then you should consider surgery at 52 millimeters. Whereas in a patient with high surgical risk, then surgery is considered at 55 millimeters. And I think this slide pretty much sums it up. Another thing in the 2024 ESC guidelines that is pretty nicely illustrated is heritable thoracic aortic diseases. And this just shows how in the genetic technology improves how we treat these patients. So first of all, if a patient is suspected to have a thoracic aortic disease that is related to a heritable condition, and specifically those at a younger age of less than 60, and you should consider family features of family histories of aortic diseases or syndromic features of Marfan, Loeys-Dietz, etc. And basically, the guidelines recommend, with a class 1 recommendation, to refer to a center with experience of care for this group. And this is because the recommended follow-up protocol for each of these diseases are different. And this really needs some experience in the center for adequate follow-up. Regardless, I think some basics in terms of patients with Marfan syndrome, treatment with a beta blocker and an ARB is basic. And for patients who are pregnant, or women who plan to be pregnant with Marfan syndrome, then prophylactic aortic root surgery can be considered if the patient is desiring pregnancy when the root is greater than 45 millimeters in diameter or 40 to 45 with a class 2B recommendation. So to summarize take-home messages, I know there's been a lot. I would like to emphasize again the importance of polyvascular diseases in patients with PAD. So this figure just shows how in a patients with lower limb extremity arterial disease or carotid stenosis, etc., concomitant disease in other vascular beds is very common, and this is why these patients have such poor cardiovascular outcomes. So when we're treating patients with PAD, we're focusing not only on the limb risk, but also on the MACE risk, which is the determinant of their survival. So in terms of hospital medical therapy, we focus not only on antithrombotic therapy, but also on blood pressures, glucose control, lipid control, etc. And we must remember that the outcomes of chronic limb-threatening ischemia is still very poor with contemporary treatment. You can see how 1/6 of these patients have a major amputation, and almost half of them either have a major limb event or die in 2 years. In terms of acute aortic dissection, who should get what type of intervention really depends on the type of the aortic dissection, the high-risk features of the patient, and whether the anatomy is suitable for TEVAR or not. Last but not least, for patients with aortic aneurysms, when should we prompt to go to surgery really depends on the size of the diameter, the surgical risk of these patients, and also if the patient has high-risk features in the aortic anatomy. So now that is my very quick wrap up of the PAD guidelines. There are a couple of sample questions that I would like to share for the EECC review. So first of all, this is a 32-year-old lady with Marfan syndrome, strong history of aortic diseases, asymptomatic, and she has an aortic root of 46 millimeters. This was confirmed with a CT scan and with what is the best management for this patient. And the patient is planning to have a baby. So A, continue annual surveillance and consider surgery once the diameter exceeds 50 millimeters. B, advise against pregnancy. C, commence beta blocker and refer for consideration of thoracic aortic surgery. D, commence a beta blocker and then follow up in 1 year. E is follow up in 1 year. So the answer is C. If you remember, it is a class 1 recommendation for patients with Marfan who is planning to have a surgery with an aortic diameter of more than 45 millimeters. So the patient is 46, which exceeds that. And so she should be started on a beta blocker and referred for surgery. Next, a 68-year-old gentleman with the aneurysm of 47 millimeters in diameter in the abdomen. So which of the following is most likely to have an effect on the rate of expansion of his AAA? A being blood pressure control with an ACE inhibitor, B, blood pressure control with a beta blocker, C is smoking cessation, statin therapy, and antiplatelet therapy with aspirin. Now, I think this question is a little tricky. It's not asking for what is part of the optimal medical therapy for this patient. It's really asking for the expansion rate, which intervention actually affects the expansion rate, and the answer is C. So A, B, D, and E are all crucial for this patient, possibly, but it really is the smoking cessation that has more evidence on affecting the rate of expansion of abdominal aortic aneurysms. Next is a 75-year-old woman who presents with an ulcer on the foot. There are no pulses. The Doppler signal is monophasic. Which of the following is an objective measure of tissue perfusion? So remember, we can assess the patient with lower limb PAD, with Doppler, with ABI, etc. But not every one of these actually looks at tissue perfusion. So in the choices, we have ABI, capillary filling time, TCPO2, CT, and digital subtraction angiogram. Only TCPO2 actually reflects the oxygenation of tissue in the foot. So others either demonstrate pressure or demonstrate the angiogram or the anatomy, but the perfusion with oxygenation can only be seen with a TCPO2. Last but not least, a patient, a 60-year-old male, presents with a 12-hour history of sudden leg pain. He had intermittent claudication before, but now the leg is wide with absent pulses, and there is profound motor and sensory impairment. So this is probably a case of acute limb ischemia, and which of the following procedures is rarely used for that? Now you can see how A is surgical embolectomy, B is catheter-directed thrombolysis, C being balloon angioplasty, D aspiration thrombectomy, and E surgical bypass. So even if you're not familiar with intervention in the lower limbs, you can try to figure with, say, experience from acute myocardial infarction with STEMIs, and you probably can think of in a patient with a lot of thrombus in his coronary arteries, then just plain balloon angioplasty probably will not treat the thing well. And primarily because in acute limb ischemia, there's so much thrombus, just doing balloon angioplasty often results in distal embolization and no flow in the vessel. So we probably need to add embolectomy, thrombolysis, or thrombectomy, etc. And that is all my part to share today. Thank you very much for your attention.
Right. Thank you, Donna, for the very comprehensive covering of the ESC guideline. Although it's a very lengthy guideline, included a lot of things. I understand it's going to be very difficult to cover everything in 30 minutes, and also very nice review of some of the salient points in your summary. So there is a question in the chat box. Probably we can answer that first, and then we can go to our panel to see if there's any additional question. The question was from Leslie, and the question was the risk of PAD assessed by Rutherford or Fontaine classifications. Donna, would you want to take that?
I think this is a very important question, firstly, but I think we need to sort of clarify in terms of what type of risk we're talking about, because the Rutherford and the Fontaine really just designates the symptomatology, the symptom of the patient. And we know that the risk of amputation really depends on a lot of other things. So, for example, the Rutherford classification is also used for acute limb ischemia, but in acute limb ischemia, it's not the same table that I showed in my presentation. And in that, it's to assess the viability of the limb. So that's another story. And for patients with chronic symptomatic PAD, it's the presentation of the level of tissue loss that I think is most related to outcomes. So we know that patients with chronic limb-threatening ischemia from 4 to 6 are a group of patients with worse outcomes. And of course, with a higher, say 5 to 6, they are at higher risk of major limb events. But specifically, the amputation risk, like if you're looking for a numerical percentage of 1-year amputation risk, in patients with wounds, you need to look at the Wi-Fi score. So the Rutherford grade of 5 or 6 does not give you a number of how much or what percent of amputation incidence is for this patient in 1 year. And the Wi-Fi score, I think, better illustrates that because it also implements infection and the size of the wound into the assessment. But if we're looking at cardiovascular risk, then I think cardiovascular risk is another story. So all PAD patients are elevated cardiovascular risk, regardless of the the severity of the PAD itself. We have seen that patients with chronic limb-threatening ischemia are very easy to have events that are not just cardiovascular in essence. We can look at the Basel II trial where the primary outcome was amputation-free survival. And I think the mortality rate of both arms were like more than 50%. So a lot of these patients die due to non-cardiovascular causes also. They are very prone to sepsis, infectious diseases, etc. So I think this question is very important, but we really need to clarify what type of risk we're talking about when we try to use the best tool for that.
All right. And we also have another question. So I think it's going to be very difficult to cover the whole entire guideline in 30 minutes. So I'm glad that Donna didn't actually go into the specific interventional treatment, because once you go into that, there's going to be a lot of controversy. But there's the question on the medical treatment, specifically on the issue of cilostazol. So in the guideline, is there any? I think there is some wording on cilostazol. On the usage of it in the symptomatic claudications. Donna, you want to add on some first?
Yeah, so cilostazol and pentoxifillin are both drugs that are they are used for symptomatic PADs, more specifically claudication. So it's a drug for claudication. Now, the evidence of these drugs improving survival or improving limb events risk is not that sufficient. In the ESC guidelines, they specifically said that these drugs can be considered for improvement of symptoms, but also in the ESVS and ACC guidelines, they reminded that these drugs are only for symptom improvement. It's not for risk reduction. But I think with cilostazol, there is some data from the Japanese group. The Japanese doctors have looked at the reduction of limb events and repeat revascularization with the use of cilostazol. So I think there's maybe still some space for discussion with that drug. But currently in the European and the US guidelines, these drugs are primarily for improvement of claudication only and not for reduction of limb events.
Right, thank you. And since this is a guideline review, so I just want to remind everyone that cilostazol in the ESC guideline doesn't have a specific class of recommendations. There's just a sentence covering that cilostazol might be considered, and also reminding us of the risks of using cilostazol on top of other antithrombotic agents such as aspirin or rivaroxaban, because of the bleeding risk, and also the contraindication of the cilostazol in patients with heart failure, which is a very common comorbidity in patients with PAD. The ACC does have a specific recommendation, a 2B recommendation for cilostazol, but again, not a very strong recommendation, just a reminder. So there's one more question. Probably we can tackle that one, and then we can go to Dr. Wong's presentation. So is there any place for high dose rivaroxaban, 50 milligrams, 21 days? So that's actually now the dosage that mentioned here is the loading dose for venous thromboembolism. I'm sure Dr. Wong is going to cover more on that part for the acute thrombi. For arterial thrombus, I think it's the same for venous and arterial. It's the loading dose for antithrombotic regime for the rivaroxaban dosage that was mentioned there. Right. So any other comment from the panel? If not, then we are right on time to go to Dr. Wong's presentation. So Next, thank you, Donna, very much for your very comprehensive review. So next, I would like to introduce Dr. Wong Wei. Dr. Wong graduated from the University of Malaya, and he's now working as a consultant cardiologist and also a board-certified interventional cardiologist in the Tan Tock Seng Hospital in Singapore. So Dr. Wong is going to enlighten us on some of the guideline updates on the venous thromboembolism. So Dr. Wong, please. So wait, you might need to tune up your mic.
All right. Okay. I think
Yeah,
that sounds good.
very good.
Okay.
Yeah.
All right. So thanks a lot, Prof, for the kind introduction. So I'm Shin Wei, actually from Tan Tock Seng Hospital, Singapore. So probably my talk is probably not as interesting as Donna because we are going to pivot to a forgotten chamber in terms of the venous part of the body. Okay. So we have probably close to 30 minutes. So I try to cover as much as possible. I have about 40 plus slides to go. Okay. Right. So no kind of interesting disclosure apart from Ezman still owing me a cup of coffees as well. Okay. Right. So basically we start off with PE or pulmonary embolism. So the outline is basically to look at the epidemiology, the risk factors, most importantly, how do you diagnose them, and basically how do you kind of re-stratify them, and also what are the prognostication tools that we use. Then we will pivot to acute phase treatment, the long-term treatment, as well as in special population, like PE in pregnancy as well as cancer. Okay, so just some disclaimer. I'm not going to talk about these recent trials. They are going to be released or pending. So like Ultima, High Pito, Pillars 2, and also the recently announced OncoPE trial, as well as the API-CAT trial that was just released in ACC. Okay, so PE guidelines, unlike aortic guidelines, is pretty old. So the last guidelines was back in 2019, and the previous one was about 2014. So if you look at what is on the horizon, ESC guidelines, there's actually no PE guidelines going to be published for the next two years. So if you look at the comparison between 2014 and 2019, the class 1 is being in some kind of stated for rescue thrombolytic therapy for patients that deteriorate hemodynamically. And also there's introduction of certain risk stratification, like with the use of PASI scores, RV imaging, as well as setup of a PERT team to kind of have a multi-D kind of therapy, or in terms of somehow discussion when you have a patient that has a pulmonary embolism. But don't worry. So if you wait for a couple of months, hopefully the American is going to come up with some form of guidelines. So acute PE is going to come out in the third quarter of this year, and hopefully gain sort of shed some light towards the treatment of PE. Okay, so more towards PE. So it's actually more common than you think, and it affects about 1 in 1,000 persons annually, and it can be pretty deadly. So about 1 to 5% in most of the registry. So the patients may survive the initial onset of PE, but later on, they may have some morbidity. So this may be in terms of CTEPH, chronic thromboembolic pulmonary hypertension, or because of the danger of the treatment from the oral anticoagulations. So they may have bleeding, they may have problems with bridging, let's say they need to go for surgery and things like that. So risk factors, it's something that is very important, and this is evidently in most guidelines. And this is kind of a cornerstone on how we assess patients that has PE. Okay, so the risk factors that are considered strong would be patient that has a fractured lower limb. Basically, if the patient is being hospitalized for heart failure or AF, hip or knee replacement, and hence I'm sure that a lot of us, if we encounter patients, if we have surgeons that has patient that come in for hip and knee replacement, we will upfront put them on some form of anticoagulations because these form a strong risk factors for PE. And obviously, if the patient has major trauma, MI, previous VTE, and spinal cord injury, so all these are very strong risk factors for pulmonary embolism. And vice versa, there are also risk factors that are not too strong if this patient has a bed rest for more than 3 days, and patient that has immobility, increasing age, obesity, pregnancy, and so on and so forth. So interesting to note, oral contraceptives, okay, so they are kind of graded in terms of severity or in terms of a risk of PE associated with it. So we have combined pills that has probably about 2 to 6 times of increased risk in PE. We have the third generation OCPs that contains desogestrel and gestodin, which is in fact has higher risk of PE than second generation OCPs. But the intrauterine devices or the progesterone only pills has no increase in VTE risk as compared to the general population. For patients that require postmenopausal therapy, it's really depending on what are the combination that's being utilized. So there are those that fall in between with the moderate risk factors. So I'm sure we have patient that has intravascular catheters, we have patient that has lines, central lines, and intravenous catheters and lines as well. So all these pose moderate risk factors for primary embolism, and certainly infection and cancer will be the bulk of it. Okay, so this is kind of a mandatory slides that is appearing in all PE talks. Okay, so what we don't want, and obviously don't want to bore you guys with the pathophysiology. So when you have sudden increase in RV afterload in a patient that has acute PE, so the patient will have, first of all, RV dilatation, increased wall tension, and basically you get ischemia, reduce in RV contractility, RV output, and hence hypotension. So this is important to help us to know what is the trajectory of patients that suffers with pulmonary embolism. So diagnosis, it's actually pretty straightforward. Okay, so I think D-dimer, I would say, the blood test is pretty important. It has a very high negative predictive value, but the specificity decreases with age. So in the guidelines, so there's a kind of a formula that you use age cutoff times 10 for a patient that has aged more than 50 years old and above. Okay, so basically this is pretty useful if you have a patient that has kind of a low to intermediate probability of having a PE, and patient coming with some form of very vague dyspnea or shortness of breath of unknown origin. It's like BNP that you want to kind of rule it out. And but if it's positive, then you need to be kind of taking into consideration the clinical context. Okay, so CTPA, it's the kind of the go-to for diagnosis of PE. I mean, CT is kind of the donut of truth, right? So basically, CTPA, the strength is kind of readily available to most of the institution and settings. And obviously, the weakness or kind of a limitation is probably the contrast usage, as well as the radiation issues. And but the strength kind of outweigh the risk most of the time. Okay, so CT, apart from giving us the kind of the whether there is or there isn't PE, it is pretty important to give us the other parameters, which is whether this patient has a dilated RV to LV ratio. Most of the time, the data that is quoted is basically if your ratio is more than 0.9 to 1, there's increased risk in terms of hazard ratios, about from 3 to 5, in terms of PE-related mortality, as well as whether patients will survive the hospital stay. Okay, so there are other imaging modalities that are probably not very useful. So VQ scan, it's kind of you can exclude PE if the perfusion is normal, but it's not really readily available most of the time. And you can have the usual SPECT scan. And lower limb ultrasound is something that I would say is because point of care ultrasound is kind of pretty the in thing nowadays. So if the patient has a DVD positive, so you found a clot in the lower limb, then you can probably accept the diagnosis of PE with a very high specificity in the correct clinical context. So echo is kind of it's like when you do a POCUS or point of care ultrasound, since you have a probe there, you must also scan the heart, right? So these are the features of echo findings that I would drill my residents to get of it. So basically, echo in general has a modest negative predictive value. So if you do not find any of these signs of RV impairment, you cannot exclude PE, but it's just that even if you have signs of RV dilatation, or if you have some form of flattened IVS, intraventricular septum, it may mean something, but you just need to take into account of the whole picture and clinical context. And obviously, I would say that if you see a clot or clot in transit, and then it's pretty likely that you are dealing with PE. So if you once a CT scan is being done, and what's next, right? So basically, once CT scan is done, you will basically look at the RV, whether it's dilated. You look at the clot burden, okay, as well as IVC reflux. The more features you have, the high likelihood that patient is not going to do well. Okay, so the other markers that we always send off when the patient has PE will be troponin and BNP. So if the patient has elevated troponin, the odds ratio is about 5 and above for in-hospital mortality. And likewise for BNP, if it's raised, it's about 10 to 23% of MACE associated with elevated BNP. Other markers that is most of the time that is being sent off will be lactate for signs of hypoperfusion, and creatinine, because most of the time you will think about dosing your anticoagulations, and also a contrast that was given when you deliver this patient for a CT. So this was basically the original score developed by, I think, Dr. Odrzewski years ago. I'm sure we can't remember all 11 variables. So bear in mind, the initial development of this score is basically to re-stratify patient. Okay, so based on the study and validation protocol, so if the patient has a very low kind of categories, is like class 1 and class 2, most of the time you can technically safely discharge the patient and do as an outpatient treatment, and because it is associated with pretty low 30 days mortality. And this is also the kind of a go-to slide that is pretty important and is guideline based. And this form kind of for trials, we always use this as a go-to to stratify patients. So from the first get-go, if the patient has hemodynamic compromise, so let's say if the patient has low blood pressure, or the patient needs vasopressor to sustain the blood pressure, then it is considered as high risk. So the other group that you need to really stratify will be the intermediate group, okay? Because if the patient has RV dysfunction or elevated cardiac troponin, and this will constitute an intermediate high group. Basically, if you look at it, the group that keeps me at night is basically the intermediate high, because you are not sure when is this group of patients going to deteriorate to high risk group, and whether or not your therapy is going to work. Okay, and obviously the low risk group and the intermediate low does not really matters that much, because these patients tend to do well in the hospital. Okay, so next we are going to pivot towards the management part. Okay, so basically for high risk P group, those that has hemodynamic compromise, oxygenation is important. Okay, and I would sort of avoid intubation as much as possible. And hemodynamic support forms a major role. Okay, so in the proper settings, if you have VA ECMO support, that would be the go-to options for cardiac arrest patient or peri-arrest patient. If you want to start something to support the patient, so noradrenaline would be a go-to drug. And a second agent will be things like vasopressin, that is kind of neutral in terms of pulmonary vascular resistance. And I know that dilator, it's kind of arbitrary. Some guidelines favor dobutamine, some guidelines favor levosimendan. But to be cautious in terms of volume loading, because these patients, if you are just going to load them with fluids, the RV is going to fail and the patient is going to get into hypotensive shock. Okay, so anticoagulation is actually something that you would like to upfront to be giving this patient. Heparin is preferred in this category. So after stabilizing the patient, the next go-to options would be reperfusion. Okay, thrombolytics, be it TPA, streptokinase, or urokinase, it's a go-to drug. It's a kind of a first-line options. And there are obviously tons of contraindications. And I'm sure everyone knows because we do lytics for MI, we do lytics for stroke, and these form the contraindications to lytics. And if the patient failed lytics or there are contraindications, you need to think of surgical embolectomy. Okay, so the up and coming therapies would be catheter directed therapy or CDTs. In this guideline, which is 2019, it's actually still a 2A, 2B kind of recommendations. So for the vast majority of the patient, that's the intermediate, high or low risk group, you would start them on anticoagulations, okay, be it low molecular weight heparin from the Paranox, and NOAC will be preferred over a vitamin K antagonist like warfarin, but is not recommended for renal impairment, pregnancy, lactating mothers, and patient that has antiphospholipid syndrome. Okay, for rescue therapy, okay, so reperfusion with lytics if the patient deteriorate, and as Python 3, Python 2 kind of data, so there is no routine thrombolytics being given for this patient. So next would be the kind of a favorite, right? IVC filters. So based on this guideline, so the focus of this talk is basically to be kind of heavy on guidelines. So IVC filters should be considered in acute patient, acute PE that has absolute contraindications with anticoagulation. And the other group would be in a patient that has recurrent PE despite therapeutic anticoagulation. And it's not a routine thing that we should do. So this is also another slide that I think we need to be pay much attention. So the first line would be if the patient is on some form of parenteral anticoagulation, so you bridge them to vitamin K antagonists like warfarin, and then you continue them for 3 months. So for rivaroxaban and apixaban, you have a special intensification phase. So for rivaroxaban, it will be 21 days with 50 milligram BD. For apixaban, it will be 10 milligram BD for 7 days. Then after that, you continue with some form of maintenance phase. For edoxaban and dabigatran, based on the trials, you need to bridge them with low molecular weight heparin for 5 days before giving them edoxaban and dabigatran. And the bottom line is you should anticoag them for 3 months regardless of the etiologies. But for patient that has lower risk of recurrence, meaning those that has higher risk factors, let's say in surgery, confined to bed for a couple of days, you probably can get along with 3 months of anticoagulations. But in the patient that has a high risk of recurrence, unfortunately, it will be indefinite. Okay, so patient that has active cancer, patient that has one or more recurrent kind of episodes of VTE, and the other major group that you need to pay attention will be group with antiphospholipid syndrome. So I would say the majority of patients will be in this group, which is the intermediate, and we will crack our head most of the time. Are you going to go 3 months, 6 months, 1 year down the line? Okay, so basically in this group of patients, it's only 2A recommendation for extended duration of anticoag. So if we are giving anticoagulation for kind of extended period, so you need to think about a reduced dose of DOACs, so apixaban 2.5 BD or rivaroxaban 10 BD in this group of patients. So special attention for this group of patient would be malignancy with PE. So if a patient has active cancer, I'm talking about active cancer, the guidelines suggest low molecular heparin for 6 months over vitamin K antagonists. Obviously, sometimes because this is kind of a subcutaneous injection, it will be a bit problematic. Caregiver training may need to be instituted. And the edoxaban and rivaroxaban can be an alternative for low molecular heparin, but this is in the caveat of in the patient that does not have GI cancer. And unfortunately, this will be a patient that you have to go all out, okay, in terms of indefinite duration or until the patient is cured from the underlying malignancy. Okay, and this is going to be testable in most of the questions as well. So the other groups that is going to be important with pregnancy. So D-dimer is probably not going to be very reliable because this group pregnant ladies, they tend to have D-dimer that's elevated, so you kind of difficult to tell. Okay, so most patients will get a chest X-ray, ultrasound lower limb, and then if the X-ray is abnormal for whatever reason, or your ultrasound is not reliable, or it is positive, then you probably need to consider CTPA scan or perfusion scan. So most of the time, we are worried about fetal exposure. So chest X-ray is about less than 0.1 milligray. If you go to CTPA, it's close about 50 times in terms of as compared to the chest X-ray, which is significant, but to take into grand scheme of things, probably you need to save the mom as well, okay, which is pretty important. So the treatment of choice in the correct context, you need to consider AFE or amniotic fluid embolism, and low molecular heparin is kind of the go-to drug. And if the patient is high risk, is actively crashing, you probably need to go all out with thrombolytics systemically. And NOACs, because it's not proven in this group of patients. And you need to be careful because if the patient is going for operation, C-section and things like that, you probably need to hold your anticoagulation for about 24 hours before your spinal epidural. So we move on to CTEPH. So CTEPH is basically you diagnose kind of if the patient has some form of dyspnea or functional limitation after 3 to 6 months of the index PE. You do a TTE. You determine the probability of pH, and then you look at their risk factors as well. If they have elevated biomarkers, then you tend to do a VQ scan. And then if it's positive, then you probably need to refer to PH or CTEPH expert center for further treatment. Okay, so we are going to pivot to a not so interesting stuff. So in terms of VT in the low limbs for this, and this is a second consensus which is published in 2022, a bit more recent as compared to the PE guidelines. Okay, the majority of the treatment options are kind of similar with PE. Okay, so if you look at it, I'm going to raise this slides a little bit because the risk factors are essentially the same in terms of the strong and the moderate risk factors. This I put it on the right will be those with PE, and on the left will be those for VTE. So it's kind of a similar in terms of risk factors. So diagnosis is the same. If you have a low risk group patients coming with unilateral low venous swelling, you want to rule out DVT, you can do a D-dimer, and if you can pair it with modified Wells criteria to give a sense of whether this patient has a DVT. Okay, if D-dimer is positive and is high probability, you probably need to go ahead with the ultrasound. And we have a group which is the distal DVT. And in a low risk group patient, you can tend to go with a shorter duration of treatment, about 4 to 6 weeks. And if a high risk patient of a proximal DVT, you tend to go with 3 months in terms of anticoagulation. So management, I'm going to it's essentially the same as PE. So for non-cancer patients, it's anticoag for 3 months, and NOAC is preferred in this group of patients. Compression is important, and you tend to follow up them with ultrasound and look for post-thrombotic syndrome. It's akin to the CTEPH patients in PE. So you may tend to stop anticoagulation, had a shared decision-making with the patient, risk-benefit ratio, whether you want to extend the anticoagulation based on the consult. So for patient that has active malignancy, you tend to prefer low molecular weight heparin for the initial, same for initial treatment, and same for long-term treatment. So low molecular heparin is recommended over warfarin. And in a patient that is unstable, or you are not sure which direction this patient is heading, or there's some form of possible drug infection, then obviously you may need to go to your low molecular weight heparin. And so it's basically the same thing. So if the patient, if you want to transit to edoxaban and rivaroxaban, this is in the setting of without GI or urothelial cancer. And for apixaban is a patient that does not have brain cancer or acute leukemia. So for catechol-direct therapy, it's not routinely done, okay? And it's only reserved for patient that has in a very severe case, and it performed in the experience center. And for patient that we do CDTs, not just stenting thrombus or thrombus removal are not recommended, Okay, so same thing with IVC filter. So if the patient has some form of contraindication to anticoag or in the setting of recurrent VTE, then you can consider IVC filter. So in the patient that has proximal DVT, immediate compression is kind of advocated because it's associated with early mobilization and walking exercise to relieve acute venous symptoms like congestion. So suffice to say it's the same. So basically for apixaban rivarox, so you have some form of intensification therapy, and then you transit to the lower dose. And for extended therapy, you may go down to an even lower dose. But for dabigatran and edoxaban, you need to precede them or kind of bridge them with low molecular heparin for a couple of days before you go to the oral therapy. And this is kind of the usual therapy. If you want to kind of start them with low molecular heparin, then after that you bridge them with oral warfarin. Okay, right. Okay, so risk of recurrence, I would say kind of similar. If you have lower risk of recurrence, you can discontinue, talk to the patient. If it's intermediate risk factors, okay, so or recurrence, so you probably need to consider the extended duration of oral anticoagulation. So reduced dose of Epix or rivaroxaban can be considered. And in high risk group patient, those with active cancer, antiphospholipid syndrome, major hereditary thrombophilia or strong family history, obviously they are all asterixes and subnote to it. And then you probably need to think of lifelong anticoagulation. Okay, so I will end this talk, but I think we'll move on to some questions. So I will probably give a couple of seconds to look through this question. So regarding the diagnosis of PE, so the best of 5 kind of options. So S1Q3D3 pattern on ECG is commonly seen. So on chest X-ray, fractional sign refer to an area of regional oligemia distal to an occlusive PE. All patients are hypoxemic. Syncope suggests high burden of proximal PE. A large unilateral pleural effusion on chest X-ray will be typical. So I'm going to pause here for a couple of seconds to sort of just you guys to have a look. Think okay. So I think it's pretty clear. The answer is D. Okay. So we know that syncope is a very dangerous sign. Okay, it's a very concerning symptoms because when a patient has syncope or present with syncope, it really suggests the PE burden or the clot burden is extremely proximal and it's probably pretty high. And this is probably a kind of a group that you probably need to start treatment early. And because the clot is probably big enough to occlude your RV outflow tract and compromise on your LV feeling and hence hypotension and hence patient pass out. Okay, so in terms of the rest of the options, so S1Q3D3, it's pretty rare. I would say it's probably 10 to 20%. And this ECG is definitely not specific. And fractional sign is basically a sign of enlarged pulmonary artery. It can mean a lot of things. It can mean patient has underlying pulmonary hypertension. Okay, so we move on to question 2. So a middle-aged gentleman is presented with unprovoked proximal DVT. So he has a past history of P a couple of years back with no provoking factors. He was treated with a 3-month course of warfarin, which was terminated due to an upper GI bleed and with an unexplained INR of 8. So what's the appropriate treatment of choice? So insert IVC filter, extended therapy with warfarin, extended therapy with low molecular heparin, DOACs, or catheter-directed thrombolytics. So we pause a couple of seconds just to get the answer. Okay, so the answer is D. Let me have a look. So it's extended therapy with DOACs. So this is the second instance of a DVT in the high-risk group patient. Okay, so I would say that extended therapy is recommended. In view of previous GIB, we probably don't want to go warfarin again. If and only if there's absolute contraindication with anticoag, then you may consider IVC filter. CDTs or thrombolytic therapy is only recommended for symptomatic iliofemoral DVT. In the absence of active cancer, extended therapy with DOACs is preferred over low molecular weight heparin. I think this is my last slide. Thank you so much for your attention. I'll just unshare the screen.
Right.
Thank you.
Thank you, Dr. Wong, for the very comprehensive, again, very mammoth task of covering such a large volume of information in such a short period of time. As Dr. Wong mentioned, the guideline on PE is pretty outdated for both the ACC and the ESC. And fortunately, they're thinking of updating their guidelines. Hopefully, we're going to have more guidance in particular the management of intermediate PE from the ACC and also the ESC. There are a couple of questions on the live box, so I'm just going to read through a couple of them and see what the panel want to take them on. The first question is concerning the use of anticoagulation during the acute phase, I suppose. How long do you give the parenteral anticoagulation before switching to oral drugs in the VTE? So, any of panel want to take this question?
I think I can take this. So basically for the VT is pretty standard. Most for logistic reasons as well as practical reasons. So most of the patients, if they're admitted to ED to the ward, they will just get the jab of low molecular heparin or whatnot. Okay. So the next day, if the patient is cruising well, and you probably get an echo, you get risk factor checks, you may need to look through the patients and see what it is. And technically, it's pretty safe to transit to oral anticoagulation if they are well in the first 24 to 48 hours, because the first 24, 48 hours will be the dangerous period. Obviously, this depends on the clot burden and how late they present as well. So most of us, within the first 24, 48 hours, we are in a stable patient, we will transit them to some form of oral anticoagulation. And I think that I hope answered that questions. And I think I can answer the other bit in terms of
Right. So the next question is on the IVC filter. So I think IVC filters, the role, the recommendation is pretty clear for the indication for filters in terms of adjuvant therapy or additional therapy on top of anticoagulations, is that is not indicated. It's only indicated in patients who has a contraindication to anticoagulation. I think that's pretty clear. What's not clear is the additional use of filter in patient who has a proximal DVT and also who has a high risk PE, for example, who has a very poor cardiopulmonary reserve. Then in those cases, I think in the hematology guideline and also in the chest guidelines, and probably you can consider it as a 2B classification of using filter in those patients with a poor cardiopulmonary reserve and also with a larger clot burden, such as a very proximal DVT. But I think in the ESC guideline, they didn't specifically specify the use of filter in those circumstances. Dr. Wong, do you want to supplement on this?
No, not really. I think I agree with you. So I think hopefully the Americans have something for us to say in this third quarter. But I would guess that when you have a unfortunate patient that has DVT plus PE, I would say PE probably take precedence. And I mean, though the treatment is the same, and I think IVC filter, it's the kind of adjunct or the treatment after that, probably not acutely.
Yeah.
And at this moment, it's just reserved for patient that has absolute contraindication with anticoagulation as per what guidelines. And I think as per the chest guidelines as well, it's kind of a very, very case by case basis as well.
Yeah. All right. So, okay, the next question is a bit difficult. I think there's a lot of controversy and also there's no clear guidance on the repeat scanning, surveillance scanning in patient who has a DVT. So would you re-scan the patient in your usual practice in a patient who has a VTE or DVT after anticoagulation, supposedly?
Thanks a lot, Prof. No, we don't rescan them, to be honest. We don't rescan the patients that has DVT and after completion of a course of anticoagulation. We tend not to rescan them. I think that question may differ if you're talking about extended duration of anticoagulations. I mean, some patients, they may want to see it has a clot resolved, has a clot kind of propagated and things like that. But scanning the presence of clot in the lower limb really does not tell much, to be really honest. It may be a chronicity of the clot. Same like if you rescan a patient that has a PE as well. It is in terms of perfusion and scan, in terms of CTPA itself or PE, you really can't tell the chronicity unless you are talking about in terms of the diagnosis of CTEPH. Then there are features that suggest a CTEPH in particular. But for the most intense purposes, I would say that we don't rescan the lower limb post DVT or the PE post a course of therapy in terms of CTPA.
Right.
Sorry, may I just sort of interject because it's quite a relevant question and we get that a lot. And
Yes.
we try to abide by guidelines, and I think guidelines, some guidelines, the Canadian one I know at least, does not recommend specifically rescanning at 3 months, even though the onset of or the diagnosis of CTEP is made after 3 months. But I think as you get older, you want to argue less with most of your colleagues, and sometimes you just oblige. Is there any particular patient group though that you would probably deviate from said guidelines and probably just scan in your practice,
Now,
Wong?
now
Mhm.
we can divide them into two groups. One is
Okay.
the patient with PE, and the other is a group patient with a DVT.
Yeah.
So for patient with DVT, I think the situation in which you will scan the patient is when the patient remains symptomatic with
Yeah. Yeah. Fair.
swelling and also any sign of post-thrombotic syndrome. Those are the patient that you might want to rescan them to see if there's any residual clot or any occlusion, especially proximal iliac occlusion they want to intervene on with endovascular therapy. For CTEP patient, I think in the guideline there is some recommendations,
Mm.
not for rescanning with CT, but rescanning with echocardiogram follow-ups. So those are very important because you want to see if there is any persistent elevation of pulmonary pressure and also
Mm.
other dysfunction, especially if you didn't intervene on the patient with any of those fancy endovascular therapy, but with just anticoagulation. You do want to see if the patient develop any persistent elevation of pulmonary pressure on echocardiogram, not with CT.
That was
So
CT.
so those are some of my take on the guideline as well. As for the anticoagulation, for duration of anticoagulation, the guideline didn't really recommend deciding the duration based on the rescanning result. But in hematology guideline, they do recommend, they do have a wording that if there's residual persistent clot on follow-up scan, you can consider extending the anticoagulation. So as Dr. Wong said, if that's something that influence the decision of the patient or yourself, then you can consider scanning them just to decide if the patient needs to be put on an extended period of anticoagulations. Right, so the last question is evidence to support NOAC use in antiphosphate lipid syndrome. Dr. Wong, you want to tackle that?
Yeah, sure. Okay. Technically, the data is pretty limited. It's I think it's the same thing for DOACs in LV thrombus. I know before the Riva War trial kind of came out. So I would say that in fact, antiphospholipid syndrome, based on even the EULA, the European rheumatology guidelines, they don't recommend DOACs. They wanted vitamin K antagonist, which is warfarin. It's just because there is arterial and venous thromboembolism, to be very specific,
Mhm.
and the risk of recurring in terms of clotting and embolizing is very, very high. So, and hence the recommendation, even based on the latest EULA guideline, is still warfarin, vitamin K antagonist, and not DOACs.
Yes. Agree. In fact, there is, I think, there's a paper specifically studying patient with antiphospholipid syndrome.
Excellent.
I think it's a rivaroxaban versus warfarin. I forgot the name of the paper,
Yeah.
which shows that the rivaroxaban is indeed associated with increased risk of recurrent not thromboembolism, not venous, but arterial or venous thromboembolism. So I think if the patient can tolerate warfarin, warfarin is a better choice than NOAC in such group of patients. Right, so I think that's pretty much a wrap up. Yeah, Donna said that's a trap trial, so very, very thank you very much. So I think that pretty much wrap up our very informative night of reviewing both the arterial as well as the venous guidelines. And thank you, Donna and Dr. Wong, for your very laborious preparation of such a comprehensive review of these two lengthy guidelines. And hopefully, in the future, we will have updates on the management of PE as well as DVT from the new guideline as well. So thank you very much. Ezman, do you have any other thing to add?
No, I think wonderful talk, and thank you very much, Donna. Thank you very much, for sort of helping out this time around. The only thing I would say is to those viewers who are watching, this is actually the final episode of this season, so you won't be seeing us anymore next month, sadly. But hopefully, the second half of the year, we'll probably commence with season 3. And you probably see my face if John wants to hire me again. But otherwise, we'll be seeing most people, hopefully, in Busan next week as part of the
Yep.
APSC Congress. Yeah. So hopefully to see you guys there. I know most of you are coming, and that's about it. So thank you very much, Guan Ming, as well for helping co-chair. I'd probably be hopeless with all these topics if it wasn't for you. So thank you, and I guess that's it. So good night, everyone. Stay safe,
Right.
and see you guys next week.
Good night. See you in Busan.
See you,
Bye.
Busan.